So today I want to talk to you all about the brave new world of anti-amyloid antibodies. Is there any hope here, or is it all a lot of hype? My goals are twofold. One, if you're already an expert on this topic, I hope you come away with at least one new clinical pearl. I want this to be a meaningful use of your time. And if you're just starting to learn about this topic, it's been in the news a lot. Thanksgiving is coming up next week. You might be getting some questions from your aunts and uncles, so I hope I can arm you with the information you need to sound like an expert. So here are my disclosures. And here are the questions I want to answer for you. So one, what is the deal with Lecanumab? This is a very timely and hip pop culture reference, everyone. I don't know why anyone would think otherwise. What is the deal with Denanumab, and what's next? So this is my one-stop shop, one-slide overview of where we are right now. And as you can see, there was a big gap between 2003, when the last of the symptomatic therapies, memantine, was approved, and the FDA approvals for our two new monoclonal antibodies, aducanumab and lecanemab. So I just wanted to talk a little bit about the state of the art, and I wanted to compliment you by telling you what you already know. So I put this in the form of a Q&A to make it more fun. So feel free to answer in your head, or if you're bold, you can answer out loud. But which cholinesterase inhibitor is FDA approved for the treatment of mild to moderate AD dementia? All of them. Which cholinesterase inhibitor is FDA approved for severe AD dementia? That's just donepezil, although we often use rivastigmine and galantamine off-label for that purpose. Which one's FDA approved for mild to moderate Parkinson's disease dementia? That's rivastigmine. Tacrin's no longer in clinical use. It resulted in transaminitis and liver injury. And then memantine, we all know, is the NMDA receptor antagonist that's FDA approved for moderate to severe dementia. So now onto our anti-amyloid monoclonal antibodies that I'll be spending the bulk of the talk on. I won't really be talking about aducanumab. Happy to talk about it in the Q&A, but none of our providers are really offering it here. Happy to talk about why, but I want to spend the bulk of our time on Lecanemab and Denanumab, which we will, well, at least some of us will be prescribing. So what does Lecanemab do? So it has a few names. I've heard it called Leqembi and Leqembi, so choose your favorite. It's also called BAN2401. And it's a monoclonal antibody that binds to A-beta protofibrils, which are thought to be the neurotoxic formulation of amyloid beta protein. So it doesn't target the mature plaques. And it was jointly developed by Eisai and Biogen, and it got accelerated FDA approval on the basis of amyloid clearance in January, and then traditional approval in July of this year. So this is, hot off the press. So here's the punchline. Lecanemab is in yellow here, and placebo is in blue. And there was overall a difference of 0.5 points, or about half a point, on this 18-point scale called the CDR sum of boxes. So there are about 800 people, a little over 800 people in each arm of this clinical trial. And the CDR sum of boxes asks about these 6 domains, and you get a score from 0 to 3, where 3 is a higher, it suggests more impairment. And so you can see it includes questions on both cognition and ability to function. And so the question for the field really is half a point on this 18-point scale clinically significant? It is statistically significant, but is it clinically meaningful? And so one way you might think about that is to ask, is it in fact disease modifying as it claims to be? So in part what we're looking at is seeing whether those two graphs separate over time. Are there slopes changing on this score? Because that would suggest that it is in fact disease modifying. But I will note that there are people in the field who say, half a point is not meaningful. We really want to be seeing at least a 1-point difference, 1 to 3 point difference on this type of scale to say that it really means anything. And this has been studied. This is a study, I'm just doing a little sidebar here. This is a study from 2019. It used ADRC data from across the country with 19,000 individuals included overall. And what they concluded, if you can see it here, and I'll read it to you if you can, is that overall in this entire group, from people who were cognitively normal to people with severe AD, you needed a 1-point difference to be clinically meaningful. And the way they judge clinical meaningfulness is it was based on a clinician assessment. So the clinician saw them and said, yes, they've had a meaningful decline in either cognition or behavior or function or motor changes, or no, they haven't. And you can also see that as the impairment becomes greater, then the amount, the value of the change in CDR sum of boxes increases as well. So when you're cognitively normal, it's about half a point. But when you get to MCI or mild cognitive impairment, it's about a point. And then when you're at moderate to severe AD, it should be about 2 points to be clinically meaningful on the basis of this study. The other way they looked at this is instead of using an anchor like a clinician assessment of change, you can use a distribution-based assessment. So if you use half a standard deviation from baseline, then again, you're looking at a 1 to 2 point difference on a CDR sum of boxes to be clinically meaningful. But I will note the flip side of the coin, which they did identify a minimum change threshold where 70% of visits were classified as clinically meaningful change. And in that case, you only needed half a point. So Lecanemab is right on that threshold of potentially meeting this minimal change threshold. It's worth noting that 2/3 of the treatment group went from amyloid PET positive to amyloid PET negative with a centiloid value below 25. And you can see that in that graph in the upper left corner, where you see a very clear separation between placebo and lecanemab in terms of amyloid status. But what I will note, and what many of you may know, is that we now know that the degree of amyloid that you have in your brain does not correlate directly with your degree of clinical impairment. And it's really the amount of tau protein that your brain has that correlates best with your impairment. So there's not this one-to-one correlation. I'm also showing you the secondary endpoints here. These are all measures of cognitive function and functional impairment as well. And there was a statistically significant difference between drug and placebo in all of these secondary endpoints. But when we're trying to determine whether, in fact, this is disease modifying, again, I would say that in some of the measures, like the functional measure in E, there is this separation over time, change in slope over time. But in some of the other measures, I'm seeing a parallel slope that's less suggestive of disease modification. So another way, we're getting a little bit into the weeds now, so I hope you're still with me. Another way that we look at whether lecanemab is disease modifying is to see whether there are any downstream tau effects. So, when we look at, for example, a phosphorylated tau in the CSF, there is a separation between drug and placebo. However, I will note that these, all the tau PET studies and CSF tau studies were in, kind of in a subgroup analysis, and were, the numbers here are much smaller than in the overall study, and the study wasn't powered to look at this. They also noted a significant tau PET slowing of tau accumulation in the medial temporal lobe, but not in other regions. And as far as other markers of astrocytosis and neurodegeneration, the results were a little bit mixed. So how will I as a clinician explain the clinical benefits of lecanemab to our patients? I will say that this medicine does not stop, reverse, or cure Alzheimer's disease. If we have time, I'll tell you about a little asterisk to this that we've just heard about a few weeks ago, but for the most part, this remains the case, that it only modestly slows the rate of progression of Alzheimer's disease. I will tell my patients that, as a class, these anti-amyloid antibodies generally slow the rate of progression by about 30%. And this may be meaningful for them, that this results in a 6-month delay in symptom progression over the 18 months of treatment in this trial. And furthermore, that it slows the rate of transition to later stages of disease with a hazard ratio of 0.69. And so will I prescribe lecanemab to my patients? Yes, on this basis, especially the slower rate of transition to later, which I do think is clinically meaningful, I will prescribe it, but only in select patients where I think it's going to be safe and effective. I'll talk more about safety in a bit, but I will note, this is, there is by no means agreement, even within our own division. So we have providers who are going to prescribe it and others who've determined that they don't think these differences are clinically meaningful and that the benefits outweigh the potential risks here. Other things our patients should know about: it is a time commitment. It's a 60-minute intravenous infusion every 2 weeks. They have to come here every time. And that doesn't include the time beforehand where they're waiting for a chair, the time afterwards where they're being monitored for an infusion reaction, especially early on. Cost is another key point to share with our patients. So Medicare said it'll pay for 80% of the drug, but that still means that they're paying $5,300 out of pocket every year. And that doesn't include the cost of any ancillary testing. So, for example, historically, Medicare pays for about 1 MRI per year, but we're going to be doing serial MRIs, and it's a little bit unclear. Is it all going to be covered? Genetic testing often isn't covered, so that's a couple $100s. I'll talk about all the screening that we do. We do direct patients to this website. I'm giving you a little preview of it at the top half of the slide. And if you Google Stanford Lecanemab, you'll find the website right away. But this is a nice resource for patients to look at as they're thinking about this drug. So I think this is an important slide for everyone, even if you're never going to prescribe Lecanemab, but this may affect your patients. So Lecanemab patients should not be prescribed any sort of anticoagulation. They should not be on an anticoagulant when they're started on Lecanemab. We'll talk about why, all the side effects. The other key thing is that patients on Lecanemab shouldn't be treated with acute thrombolytics. And again, we'll talk about why, but that's a big change. If you're seeing patients in the emergency department, or you're on the wards and your patient has a stroke and you're thinking about acute therapies, this is a bit of a game changer. I think it's also, I remember when I was a resident, sometimes we'd have a hospital transfer, we wouldn't have the med list right away. And so on your differential, when, just keep Lecanemab in the back of your mind, maybe they're on it. But anyway, and also I'll talk more about acute neurological changes too. But they can still get a thrombectomy if they have a large vessel occlusion. So we should still be advising our patients to go to the emergency department if they have acute stroke symptoms. Antiplatelets are okay. And I'll just mention, I was at AIC over the summer, one of our big conferences, and they presented these appropriate use recommendations for Lecanemab, which came out in March. And they said, we're going to be very strict for now because of the potential side effects. And maybe we're going to be less strict in the future once we get more comfortable with this drug, but we're all sort of feeling it out. And so for now, we're going to keep things pretty strict overall. So that's one, the reasoning behind some of these recommendations. So who's appropriate for Lecanemab? So in the trial, you had to have either mild cognitive impairment or mild dementia due to Alzheimer's disease. So that means a lot of our patients with moderate to severe dementia are excluded here. In the trial, you needed to have objective impairment and episodic memory. That's no longer a part of the appropriate use criteria recommendation. So that does open the door for people who have atypical AD to get treatment if you'd like. So you did need a positive biomarker, and similarly in the real world, we need some evidence that you have amyloid so that we know that you have amyloid that we can clear with this drug. And so that means either a positive amyloid PET scan or CSF studies indicative of Alzheimer's disease. Right now, plasma-based biomarkers are not ready for prime time, but stay tuned, that may change. As far as age goes, there were limits in the trial, but you can use physician judgment outside of these ranges. This is another big one. So the MMSE range should be between 22 and 30. And so that does mean that a lot of our patients may be excluded from this drug if they're not in this range. Again, we're looking for people with relatively mild disease, or you could do a comparable score, MoCA score as well. And then although there were BMI specifications in the trial, you can use your judgment outside of these ranges. Similarly, similar to the trial, you can be on a cholinesterase inhibitor at the same time. You can be on memantine concurrently, but I think it's common sense they shouldn't be on more than one monoclonal antibody at the same time. The other key thing is that they should be on standard of care for medical illnesses and be on stable doses for all of that. And in the trial, they required a study partner. And I do think it's important in the real world too, for there to be some sort of caregiver or care partner, because they're going to be monitoring for infusion reactions. They're going to be monitoring for these adverse effects called ARIA that I'm going to be talking about with you. I do think it matters that somebody has somebody in their life who can keep an eye on this sort of thing. And, at the very least, you need to have a discussion about all the risks and benefits with your patient. Here at Stanford, we have developed a way to do an informed consent so that we make sure we go through all the relevant information. The other key things for you to know if you're prescribing Lecanemab is that there's a mandatory Medicare registry that you have to sign up your patient for in order to get coverage. And you have to do this mandatory functional activities questionnaire, or FAQ. It's pretty straightforward. You ask them these questions about writing checks and making a cup of coffee and keeping track of appointments, and then rate them on a scale of 0 to 3, with 3 being the most dependent. But that's a part. If you Google FAQ, it's easy to find, but that's something that we need to fill out. So you thought I was done. I've already gone through all this screening criteria, but wait, there's more. So first, they need to be medically stable, neurologically stable, psychiatrically stable. They shouldn't have some other comorbid dementia, which excludes a lot of our patients, unfortunately. And this is key. On their MRI, 4 is the magic number. You can't have more than 4 microhemorrhages. You can't have more than 2 lacunar infarcts, which I think we can admit a lot of our patients happen to have. You can't have severe cerebrovascular disease, and really you can't have any other major intracranial pathology, because this isn't like our other drugs. These drugs are not benign, so we have to be really careful here. No stroke or TIA within 12 months. And this is actually stricter in the appropriate use criteria than it was in the trial. In the trial, it was 12 months. But here they're saying any history of seizure, even 1 lifetime seizure, is exclusionary here. All right, we're still going. Any mental illness that could prevent them from comprehending the risks and benefits, including depression, that that could interfere with their comprehension or could result in suicidal ideation if they find out about their biomarker status or their genetic status. Any immunologic disease is exclusionary. Any immunosuppressants or monoclonal antibodies, a bleeding disorder, we talked about this, or basically any unstable medical condition. I think you're getting the point here, but this is much more strict than we're used to with really most of the drugs that we tend to prescribe. So here's my 1-slide overview of this whole checklist that we do. It's a very extensive screening process. With regard to the amyloid PET, there's no stopping criteria at the moment for Lecanemab, the way there was in the Denanumab trial, but stay tuned, that may change. The other thing is Medicare has recently announced that they're going to cover amyloid PET scans, but those decisions are going to be made on a local basis. So I think we're still trying to figure out what the coverage is going to look like, and are there going to be denials. But at least for now, that's very promising and another game changer in our field. We also do ApoE testing in everybody who's getting screened. I promise I'll go through the differential risks of ARIA with people who have the high-risk variant of Alzheimer's disease, high-risk allele E4, but we do that so that we can properly counsel patients. And the rest of this, I think we've gone through. In the criteria, they say an MRI within 1 year. Here at Stanford, we're doing an MRI within 3 months of starting treatment to make sure they don't have any concerning pathology. All right. So ARIA stands for Amyloid-Related Imaging Abnormalities. ARIA-E refers to effusions or edema, and ARIA-H refers to hemosiderin or hemorrhage. And so I imagine most of the articles you look at, and when this is textbooks, it's going to look like that upper left corner. But one point of this slide is to point out that it can be quite subtle. It does look quite a bit like the press that we've all seen. But you can get gyral swelling, you can get this edema, these sulcal effusions, and then ARIA-H can take the form of microhemorrhages, it can take the form of superficial siderosis, and then in rare cases, macrohemorrhages. So what are the rates of ARIA? Overall, the rate of ARIA in this study was 21%. And however, in the vast majority of cases, it's asymptomatic. So in the case of ARIA-E, about a quarter of patients were symptomatic. In the case of ARIA-H, it was even smaller. If they had ARIA-H without E, then only 6 of 155 participants had any symptoms at all. So I promised I was going to show you the risks with ApoE. So if you're an E4 non-carrier, risk of ARIA-E was 5%, and then that jumped to 32 or 33% if you were an E4 homozygote. And similarly with ARIA-H, if you were an E4 non-carrier, then your risk was about 12%, but that jumped to 39% if you were an E4 carrier, E4 homozygote. So it's a huge difference in terms of your risk that we need to counsel patients on. And in fact, in my practice, I'm not currently offering Lecanemab to patients who are E4 homozygotes, in part for this reason, but also another slide, if we have time, I'll show you from an efficacy standpoint as well. But many of our providers are offering it. They're just offering counseling about what it means in terms of their risk. So if you do get symptoms of ARIA, what does that look like? So sometimes the symptoms can be quite mild. It can be a headaches and dizziness, but in rare cases, it can be quite serious. So I was alluding to this earlier, but we now have something new on our differential when somebody comes in with focal neurologic symptoms or seizures or encephalopathy. We do have a medication, Lecanemab medication guide that we've developed. So that's available to you all if you want a copy to provide to patients as they consider whether to go on this drug or not. On a somber note, there have been some patients who've passed away due to Lecanemab. So there were none that passed away in the original phase 3 trial, but in the open label extension, there have been 3 patients who've passed away. 2 of them were on anticoagulation at the time, and the third likely had pre-existing CAA that predisposed her. As far as aducanumab goes, there was a patient who received an acute thrombolytic who passed away. Overall, in the phase 3 Clarity trial, the risk of a macrohemorrhage was about 0.6% compared with 0.1% in the placebo group. But that number jumped to 2.5% if you were on Lecanemab and an anticoagulant at the same time. So this is our schedule of screening MRIs that we do here at Stanford. We've added on a few more MRIs towards the end, but I will say in the vast majority of cases, as far as Lecanemab goes, it's a little different for the others because the titration schedule was slower. But 70% of ARIA-E was detected on either the first MRI or the second MRI. The other thing is that generally ARIA-E resolves in the vast majority of cases within about 4 months. ARIA-E tends to resolve. ARIA-H doesn't resolve, but it often stabilizes. So that's the pattern that we see. What do you do if you see ARIA? So the key question you need to ask is the patient symptomatic or asymptomatic? And if they're symptomatic, you stop drug, you do monthly MRIs, and then if the MRI shows that ARIA-E has resolved, ARIA-H has stabilized, and the patients and family members are willing to continue, and you're willing to continue, then you can resume Lecanemab. If they're asymptomatic, the key question you want to ask yourself is it mild ARIA or is it moderate to severe ARIA? And I'll talk about that difference in just a bit. But if they have mild ARIA, you can actually, if you're feeling comfortable with it and patient and family member are feeling comfortable, you can continue Lecanemab, but continue the monthly MRIs until the ARIA-E stabilizes or resolves. And then this all goes out the window if there are some additional criteria. In particular, if you, for example, have more than 2 episodes of ARIA, then you stop Lecanemab. That's it. No more, and then you don't apply the remainder of this criteria. So what do we mean by mild versus moderate to severe ARIA? So mild refers to, for ARIA-E, one area of flare hyperintensity that's less than 5 centimeters, or in the case of ARIA-H, less than or equal to 4 new microhemorrhages, or just one focal area of superficial siderosis. So technically, if you're comfortable and they have mild ARIA, you can continue treatment if they're not symptomatic. What are other potential side effects of Lecanemab? They're all listed here, but I wanted to point out the infusion-related reaction. So 1/4 of patients on Lecanemab had an infusion-related reaction. So worth knowing about. And what do you do about it? Well, if it's mild and it goes away before you even have time to think about stopping treatment, then you don't really need to do an intervention. But if they're feeling lightheaded or having palpitations, and you interrupt the infusion and the symptoms go away, that may mean that they need some additional symptomatic treatment before you resume treatment, maybe an antihistamine or Tylenol or NSAIDs or fluids, and they may need prophylactic medication down the road, when they get future treatments. If their symptoms are prolonged and not resolving, they may require hospitalization. For example, if they've poorly controlled hypertension that's not going away. Sometimes, in rare cases, we see life-threatening consequences. Patients can end up on pressors or on a ventilator. Hopefully, they don't get to grade 5. So I was hinting at this earlier. This was so the trial was not powered to do this type of subgroup analysis. So take it with a little bit of a grain of salt. But in terms of who benefits most from lecanemab, turns out it's white men. I can't tell you exactly why. I can say it's generally older white men, those that are over the age of 75. And it also turns out that E4 homozygotes are the least likely to benefit from lecanemab. So that's why in my personal practice, I'm not currently offering it to patients who are E4 homozygotes, but you're going to see some provider differences there. And then to continue along these lines, which of our patients are going to benefit the most? It's the people with the fewest tau tangles. So this is also hot off the press. This was announced just a couple weeks ago at one of our Alzheimer's conferences. So people at the earliest stages of disease where tau tangles are only starting to accumulate in the hippocampus and the entorhinal cortex, and they're not yet in the rest of the limbic cortex or in the neocortex, they are the most likely to benefit. And in fact, 2/3 of participants with very early AD, early stages of tau, who took lecanemab actually improved on the CDR sum of boxes. Now, in Alzheimer's disease, we never hear the word improved. We don't know the meaning of that word. But we did hear improve at this conference, and I think it was quite shocking for everybody. But again, these are, I would say we need more information, but the preliminary data is quite interesting. And there were similar patterns in terms of greatest amount of benefit with, in early stages of disease with the Denanumab trial, and also in the dominantly inherited Alzheimer's trial with another anti-amyloid antibody, gantenerumab. Okay, so this is a visual version of what I was just talking about. So on the left, you have people who did not decline on the CDR sum of boxes, and on the right are the people who improved. And on the left, 76% had no decline at 18 months if they were on drug, and on the right, 60% improved at 18 months if they did improvement. And then once you went on the open label extension and people moved from black, which is placebo, to green, which is drug, you see a similar pattern in those groups. And there was a significant difference between drug and placebo. All right, so I always like to bring it back to our patients and thinking about where we are we helping? So one thing to keep in mind is, we have a ways to go in terms of making sure that our clinical trials are representative of the population and that the results of those trials apply to everyone. So unfortunately, only 2% of participants in Clarity AD in this lecanemab phase 3 trial were Black and African American. The other issue we have to consider is, are we creating a two-tiered system? Given how expensive this drug is, even if you have Medicare, you're still paying over $5,000 a year for the drug. And are those who can't afford it going to get left behind? And then, a couple other caveats. We don't know if amyloid plaque removal correlates with the primary outcome measure. I credit Mike for pointing this out, and he's written an excellent paper on this. And the other thing he's pointed out is that, the risk of ARIA it potentially unblinds patients and their caregivers. And keep in mind that our primary outcome measure is this semi-structured interview where we're asking people how someone is doing. But if they develop ARIA and suddenly they've stopped their infusion and suddenly they're getting monthly MRIs, then many of them are effectively unblinded. Or if they have an infusion reaction, many of them are potentially unblinded. And so it would be helpful to have spaghetti plots of participants with instances of ARIA labeled, but that hasn't been published yet. Okay, so before we get to Denanumab, I'm going to give your brains a little bit of a break. You can also stretch a little bit, but I like corny jokes, so I'm going to give you a couple corny jokes. How does a brain say hello? It gives a brain wave. What is the sleeping brain's favorite musical group? REM. All my references are extremely hip and topical. What has heads and tails but no brain? A coin. And finally, when does the brain get afraid? When it loses its nerve. All right, so what about Denanumab? All right, so this is the one slide overview. There's some key differences between the Lecanemab trial and the Denanumab trial. So first of all, in order to screen into this trial, you had to have both evidence of both amyloid and tau pathology at the very beginning, at the outset of the trial. There are a comparable number of people in the drug and placebo arms compared with Lecanemab, but another key difference is that this drug was administered every 4 weeks instead of every 2 weeks, so a little less burdensome. Unfortunately, we don't live in a perfect world, so they used a different primary outcome measure than the Lecanemab trial, which makes our lives a little more difficult. But this is a composite score that includes measures of cognition and measures of function. You get a score from 0 to 144. In contrast to the CDR sum of boxes, where a higher score means you have greater impairment, here a lower score means greater impairment. And they measured, the durations of the trials were comparable. So this was the primary outcome was measured at 76 weeks. So overall, as you can see, there was a difference of a change in 6 points in the low medium tau population on Denanumab and 10 points in both the low medium population and high tau population. And so overall, there was a statistically significant difference between drug and placebo in both of, compared, when you compare the low medium tau group to placebo and the combined tau group to placebo, about 3 points. It's a little bit better if you have less tau, but again, the question becomes what's clinically meaningful. And so some people say maybe you need to have worsening of 5 points if you're at a level of MCI, or 9 points at the level of AD with mild dementia. What's the difference between all these monoclonal antibodies? They all have different targets. So I think we talked about Lecanemab, it targets the protofibrils, but it does have some off-target binding. And then Gantenerumab is very similar to Aducanumab. They target plaques, and then there's some off-target fibril binding. And then Denanumab is supposed to be a little more pure and target plaques and minimize off-target binding. Some other key differences are that Denanumab had stopping criteria. So if you went below a certain amyloid PET threshold, they actually stopped Denanumab and switched you over to placebo. And the other thing is that, this population may have been very mildly worse. Instead of MMC 22 to 30, it's 22 to 28. Okay, so here's the Denanumab punchline with this primary endpoint, the IADRS. And so the key question you should be asking yourself is, are the lines separating over the time? Is this in fact disease modifying? I would argue you can't quite see it. You can't quite see that separation on these graphs like you can with Lecanemab. But in terms of the low medium tau population, you had 35% slowing of clinical progression. In the combined population, you had 22% slowing of clinical progression. So these are the things we'll be telling our patients. So they did do CDR sum of boxes as a secondary endpoint. So if you want to compare apples to apples, there was about a 0.7 point difference between drug and placebo. And I'll just remind you that Lecanemab was a half-point difference, right? So I'm not a conspiracy theorist, or I don't think so. But in supplemental document 3 called E-methods in E-table 5, I'm sure everyone's going to hunt down this table. You can find this table where they look at high tau. And you can see that on the primary outcome measure, they did not have a statistically significant difference between drug and placebo. So I think this is important to keep in mind as we're deciding, should we start our patients on Denanumab, and who should we start? But I will just say that, when I attended their presentation over the summer, they did not mention this information. But the CDR sum of boxes, the secondary endpoint I will mention, was statistically significant, there was a statistically significant difference, and it was pretty comparable overall. This is a post hoc analysis, so all the caveats that go along with that, and the numbers here are smaller as well. This is something that I think is important. So the CDR scale global is different than the CDR sum of boxes. It indicates the level of severity of Alzheimer's disease. And so there is a difference between drug and placebo in terms of how quickly you progress to the next stage of disease, the next level of severity. And the hazard ratio was about 0.6 in both tau groups. And so overall, you're saving between 4.5 to 7.5 months for these patients in terms of progression. And so it's really this slide that convinces me that for some of my patients, Denanumab may be an appropriate therapy that may have some benefit for our patients. And about half of patients on Denanumab had no change in their CDR boxes, no disease progression at the 1-year mark. In terms of changes in images, the key things that I'll point out is that, remember, there were stopping criteria at weeks 24 and 52, but by the end of the trial, week 76, about 69% had met the stopping criteria, had gotten their amyloid PET below threshold. With regard to tau PET, for some reason, they used frontal tau, and there was no significant difference between drug and placebo in terms of tau deposition in the frontal lobes, which, again, we want to see changes in tau PET because we want to see that there are downstream effects from these anti-amyloid antibodies, but we're not seeing it on this particular measure. And then one other interesting thing that has emerged in several of these trials now is that there is a greater decrease in whole brain volume. In other words, there's more atrophy in the Denanumab group than in the drug group. So that's a bit bizarre given, the clinical improvement that we're seeing on drug, but something to keep in mind. Okay, so in terms of safety, how do they compare? So in the case of Denanumab, there were 16 deaths overall, but 3 of them were deemed to be related to drug. Remember that in Lecanemab, there were 0 deaths in the phase 3, but in the open label, there were 3 patients who passed away. The overall rate of ARIA-E was 24%, and of those, a quarter were symptomatic, compared to a smaller rate of ARIA-E of 13%. Comparable amount of them were symptomatic. 20% ARIA-H in Denanumab, pretty similar in Lecanemab. Any ARIA was, just under 40% in Denanumab, and just over 20% in Lecanemab. I think that's driven by the ARIA-E rates. So, but there is a big difference between the two in terms of safety. So if you're looking to maximize safety, then certainly Lecanemab is the appropriate choice here. And then the rates of intracranial hemorrhage were pretty similar. The relationship that we saw with Lecanemab, where there was an increased risk for patients with 1 or 2 copies of E4, was also seen here. And just worth noting that the infusion-related reaction rate of 8% was lower than the 26% rate noted with Denanumab. So this is just, this paper came out yesterday, so I added it at the last minute for you all, just to let you know that Gantenerumab, the phase 3 trial results, which were presented at one of our Alzheimer's conferences, but now the peer-reviewed paper is out, was a negative trial, so didn't show benefit. So, 2 steps forward, 1 step back. But anyway, if you're hearing about Gantenerumab, just know that it was a negative trial. All right, so I want to end with a little bit of hope in case, we're making progress, but we want to see more progress. Some of us, are still waiting for that for that progress. And so in terms of what's next, we do have multiple clinical trials here at Stanford. This is the QR code if you want it for our trials website, or if you Google Stanford Memory Clinical Trials, you'll find it. But we have an Alzheimer's trial, we have a Lewy body trial, we have a dementia prevention trial, we have our wonderful ADRC, which does observational research. So please feel free to refer your patients. Happy to talk about that in the Q&A, but I'm a sub-I or a PI in some of these trials, so I don't want there to be any kind of bias or perception of bias here. But anyway, this is available to our patients. All right, so this is exciting. These are all the drugs that are currently in the pipeline for Alzheimer's disease. And the amyloid-related therapies are in red, but all the other therapies are different mechanisms. So you have inflammation, you have oxidative stress, you have synaptic plasticity, you have tau. So it's really, really exciting to look at everything coming down the pike. And it goes across the clinical spectrum from prevention of dementia to people with severe dementia. And, you have symptomatic therapies similar to cholinesterase inhibitors and memantine. And then in that green slice and the purple slice, you have the disease-modifying therapies, which we're all very excited about. In terms of which drug classes are most represented, turns out neurotransmitter receptors in phase 3 trials are the biggest group. Amyloid comes second, and then synaptic plasticity is third. But you can see, over 60% of the trials are looking at potential disease-modifying therapies. And so these are all the trials. The phase 3 are in yellow, but, we see the phase 1 through phase 3 trials. And so the big groups are inflammation, tau, amyloid, transmitter, synaptic plasticity. So we're all excited about these potential novel mechanisms and approaches for treating Alzheimer's disease. So I'll leave you with this parting thought before we get to the Q&A. The story behind this is this is a colleague outside of Stanford. I sent him an email. I don't know him. He was on the scientific advisory board for a trial that I wanted to get on, that I wanted to bring to Stanford. And this was the email that he sent me, which I thought was a very colorful description that perhaps characterizes some of the controversy that's in our field. So thank you all very much for taking the time to listen to me. I sincerely appreciate it.